Welcome, everyone. Welcome, everyone, to the 2023 PI Conference. We will get started in just a minute. Spanish interpretation is available for this session. You can access the Spanish language line by clicking the world icon on your Zoom toolbar. My name is Colleen Brock. I am Manager of Medical Programs here at IDF, and I will be your host for today's session on vaccines and PI. This important topic will be presented by our guest, Dr. Ballo. There will be time for questions at the end of the presentation. Please submit any questions you have for me in the Q&A section of the platform. Please note that our guest labeled as a technician is here to assist in today's recording. If you have IT issues as an attendee, please visit the help desk in your attendee hub. And with that, I would like to introduce Dr. Ballo. So Mark Ballo is currently professor in the Departments of Pediatrics at the University of South Florida, Morisani College of Medicine at Johns Hopkins All Children's Hospital in St. Petersburg, Florida, in the Division of Allergy and Immunology. Dr. Ballo received his medical degree from the University of Chicago School of Medicine, Chicago, Illinois. He then completed an internship and residency in pediatrics at Yale, New Haven Hospital in New Haven, Connecticut, followed by a fellowship at the University of Minnesota, hospitals in Minneapolis, Minnesota, in clinical immunology under the mentorship of Dr. Robert Good. After finishing his time in the Army at Walter Reed Hospital, Dr. Ballo joined the Department of Pediatrics, UConn School of Medicine in Farmington, Connecticut. From 1988 to 2012, Dr. Ballo was chief of the Division of Allergy, Immunology, and Pediatric Rheumatology at Women's and Children's Hospital of Buffalo, an affiliate of SUNY Buffalo School of Medicine and Biomedical Sciences. Training Program Director of the Allergy Immunology Fellowship Program, and director of the Immunobiology Laboratory. Dr. Ballo is board certified in pediatrics, allergy and immunology, and clinical laboratory immunology. Dr. Ballo was the president 2010 to 2011 of the American Academy of Allergy, Asthma, and Immunology, known as Quad AI. Dr. Ballo is also a member of the American College of Allergy, Asthma, and Immunology and the Clinical Immunology Society. He is a member of the Blood Product Advisory Committee of CBER FDA. He currently serves on the Medical Advisory Committee for the Immune Deficiency Foundation and is consulting medical director for IDF. Dr. Ballo is on the editorial boards of Journal of Allergy and Clinical Immunology. In practice, he was co-editor for Current Opinion in Allergy and Clinical Immunology between 2001 and 2018. Dr. Ballo is author or co-author of more than 200 peer-reviewed papers, 50 books or book chapters or monographs, and more than 100 abstracts. He serves as the data safety monitoring boards for 4 pharmaceutical phase 3 trials and has participated in a number of phase 3 clinical trials for immunoglobulin products. His areas of research interest are primary immune deficiency disorders and immunoglobulin IVIG replacement therapy and its mechanisms of action. Thank you so much for joining us, Dr. Ballo. You have quite the history and quite the knowledge, and we look forward to hearing your presentation today. And with that, the floor is yours.
Okay, can you hear me?
I can.
Okay, because I was a little confused why my AirPods are not working. So everything is coming through the computer.
Yes. You are doing just fine, and I can see and hear you perfectly.
All right. Well, thank you, everyone, for joining. So just some background definitions. Immunity, I'm sure most of you know some of these definitions, but we'll go through them anyway, is protection from an infectious disease. So if you're immune to a disease, you can be exposed to it without becoming infected, hopefully. Obviously, it depends on the degree of your immunity, because immunities do wane, and that's why we give booster vaccines. So a vaccine is a preparation that's used to stimulate the body's immune response against diseases. Vaccines are usually administered through needle injections, but can be administered depending on the type of vaccines by mouth or actually sprayed in the nose. So for example, there's a type of influenza vaccine that can be sprayed in the nose. We don't recommend that because that's an attenuated live viral vaccine. And we'd rather, of course, administer influenza vaccine by injection. So the vaccination is the act of introducing a vaccine into the body to protect it from a specific disease. And immunization is a process by which a person becomes protected against a disease through vaccination. The term is often used interchangeably with vaccination or inoculation. You may have heard those terms as well. Okay. So this is the type of vaccines. There's live attenuated vaccines, and you can see, some of the usual vaccines that fall into this category, such as mumps, measles, and rubella, varicella, the rotavirus, yellow fever, and BCG vaccines. Inactivated vaccines such as hepatitis A and polio, subunit recombinant and conjugate vaccines, and we'll talk more about some of these vaccines later. Meningococcal vaccine, shingles vaccine, pertussis vaccine, Prevnar, Haemophilus influenza type B vaccine, hepatitis B vaccine, and human papillomavirus vaccines. And then there's the polysaccharide vaccines, two different types, Pneumovax against pneumococcal polysaccharide, and Salmonella typhoid vaccine, toxoid vaccines, diphtheria and tetanus vaccines, mRNA vaccines. Of course, this is the COVID vaccines, Moderna and Pfizer. And viral vector vaccines is also a variation of the SARS vaccine, such as Janssen, Johnson, and the Oxford AstraZeneca COVID vaccines are viral vector vaccines. So vaccines, contain other materials, and these are listed here. So for example, they contain stabilizers, and these stabilizers can be sugars, or some of them contain gelatin. So for example, the mumps vaccine contains gelatin, and we see patients that develop an allergy to gelatin, and therefore they can develop a reaction to the mumps vaccine. They contain adjuvants, and these are added to boost the body's response to vaccines. A common one is aluminum salts. There can be residual inactivating ingredients, and these are used to kill anything that's not supposed to be in the vaccine. Formaldehyde is an example, usually in very, very low concentrations that usually are usually not a problem. So some of the vaccines are made in cell culture. So there could be residual cell culture material in vaccines. I think that the most common one that you may be aware of is influenza. And remember, there was always a lot of discussion about egg proteins in influenza vaccines, and concerned in those individuals who had egg allergy and a potential reaction against the yearly influenza booster vaccine. Well, the good news is that the influenza vaccines now have essentially negligible levels of egg protein in the vaccine. So this is no longer really an issue. There could be residual antibiotics to which a person can be allergic in the vaccines, and some examples are shown here in this slide, such as neomycin, kanamycin, and streptomycin. So if an individual is allergic to one of these vaccines, that could present a problem with administering a vaccine that, contains these antibiotics. And thimerosal is another preservative, and there was a lot of controversy about this particular preservative and as associated with disease. But it's only contained in multi-dose vials of flu vaccines. So single-dose flu vaccines do not contain thimerosal, and it has been removed from the MMR because remember, there's a big controversy about MMR vaccines in the past. No longer. So this is the 2023 recommendations for vaccination in children 7 to 18 years of age. You can get this, I got this off the CDC site. So you too can get on the CDC site and get the recommendations for children, you get the recommendations for adults. And I won't go over this in detail because this is readily available to everyone. But you can see, for example, that COVID vaccine is recommended for all children, even down to 6 months of age, which I don't have on this slide, starting at age 7. The influenza vaccine given yearly, DTaP boosters, human papillomavirus at age 11 or 12, meningococcal vaccine, both 11 and 12 and boosters at age 16, and as well as meningococcal B at between 16 and 18. And then, of course, at the bottom is catch-up vaccines if they have been inadequately vaccinated previously. But again, all this is available on the CDC site. So this is also taken from the CDC site, and the major headings on the top in green is the name of the vaccine, pregnancy, immunocompromised, excluding HIV, in which the CD4 count is below 200 or above 200, patients with asplenia or complement deficiencies, end-stage renal disease on hemodialysis, heart or lung disease, chronic liver disease, diabetes, healthcare personnel, men who have sex with men. So the red is obviously contraindicated, and if you look under the heading of immunocompromised individuals, although it doesn't really spell out that it's patients with primary immune deficiency, I think we recognize that patients with PI would fall into these categories. And obviously, live viral vaccines are contraindicated in patients with PI, including as I mentioned before, the live influenza vaccine that's given into the nose, MMR, varicella, yellow fever, rotavirus, etc. Now we use, clinical immunologists use vaccines actually for diagnosis of the type of PI that we're considering, and for further evaluation of trying to put a designation or category on a patient on what type of underlying immune deficiency they may have. And you may have heard this before, that we use both T-dependent and T-independent vaccines. The T-dependent vaccines are those that are protein antigens, such as tetanus or diphtheria. And that leads to long-lived memory B cells and plasma cells and immunoglobulins of all 4 immunoglobulin classes, GM and A and E, whereas T-independent antigens are those that are derived from polysaccharides, such as the pneumococcal polysaccharides, and they usually give mostly IgM antibodies, but also, obviously they give us IgG antibodies as well. but these plasma cells are more short-lived. And therefore, it's not surprising that after we immunize somebody with, for example, Pneumovax, the titers do go down over a period of time, say over a year or so, whereas the T-dependent vaccines, such as the tetanus, lasts a long time. So many of our patients with common variable immunodeficiency in adults still have a pretty good level of tetanus antibodies in their serum or plasma. And this may be true for other vaccines that they've received along the way. So these are some of the vaccines that we use diagnostically. The Hib is a conjugate vaccine, and therefore produces a pretty good, robust response, even in some patients with common variable immunodeficiency. The meningococcal vaccine is a conjugate vaccine, again, because it's conjugate, even though it's a polysaccharide meningococcus bacteria, because it's a conjugate vaccine, it produces a T cell dependent response. The meningococcal polysaccharide vaccine is not a conjugate vaccine and is actually no longer available. So we actually can't use that vaccine as a diagnostic vaccine, where we would use a pneumococcal polysaccharide vaccine to look at T-independent responses. We also have a pneumococcal conjugate vaccine. Perhaps the one that you're most familiar with is Prevnar 13. We now have Prevnar 20 that was just last month approved by the FDA, both for children and adults. Rabies vaccine and tetanus vaccine. The rabies vaccine we really don't use very much. There's not very much data available in patients with primary immunodeficiency. So, and I have no experience with it. So it's posted on this slide because it's a possibility of using it as a diagnostic vaccine. And of course, tetanus vaccine. So just a word about pneumococcal vaccines, because I know there's a lot of discussion about that and some controversy about that. It is an important tool for the diagnosis of primary antibody deficiency, particularly patients with selective antibody deficiency. The Pneumovax, which is purified polysaccharide antigens, contains 23 serotypes that are important in producing human disease, pneumonia, as well as ear infections and sinus infections. And you may or may not, be aware of this, but we determined that a protective level of antibody following immunization is a serum level of 1.3 micrograms per mil, or a twofold response over baseline if the baseline antibody level is already 1.3 micrograms per mil or higher. And what about the response to the serotypes? Now, there's 23 serotypes, and an adequate response is at least to 50% of the serotypes. Now, there's some controversy about this. There's some literature that says an adequate response has to be to 70 serotypes, but not all clinical immunologists is in agreement with this. We don't use Pneumovax under age 2 because they have a diminished response. In fact, I usually wait till 30 months of age before using Pneumovax as a diagnostic vaccine in children. And as I said before, we now have Prevnar 20. So you can see the Prevnar 20 has 20 different serotypes, many of them overlapping with Pneumovax. So therefore, as individuals receive Prevnar 20 as a regular immunization, scheduled immunization, it's going to make it very difficult to use Pneumovax as a diagnostic tools to look at the response to purified polysaccharide T-independent antigens in patients that we're evaluating for PI, particularly those patients that we're considering for selective antibody deficiency. So there's a lot of complexities about measuring pneumococcal antibodies to the vaccine, the number of serotypes I already mentioned, the controversy whether 50% or 70% of the serotypes, that different labs use different assays. So physicians have to be careful to send the pre-testing and the post-testing to the same lab in order to, have consistency. And then, the issue about giving conjugate vaccine in conjunction with a polysaccharide vaccine. So for example, if a patient receives a conjugate vaccine first, you can give the pneumococcal vaccine, that is Pneumovax, 8 weeks after. In fact, there could be a priming effect, that is an augmented effect. However, if a patient has received Pneumovax, that is a purified polysaccharide vaccine first, it's recommended to give any subsequent vaccines a year later. So some, patients may hear that they can't be tested with the pneumococcal polysaccharide vaccines. They have to wait a whole year for it to occur. Well, many of our patients are on immunoglobulin replacement therapy, and there is sometimes the issue whether patients have outgrown their immune deficiency. So for example, patients with selective antibody deficiency children can outgrow their immune deficiency generally around 7, 8, or 9 years of age. So it would be very productive if we had a vaccine that we could use while they're on immunoglobulin replacement therapy to determine whether their immunity has recovered and their ability to make specific antibodies to vaccine has recovered. So, but we have to be careful because obviously immunoglobulin contains specific antibodies to a lot of the vaccines that we use. So we can't use the usual vaccines that we use, for example, for testing naive patients for primary immune deficiency. So vaccines that we could potentially use is rabies vaccine. But again, as I said, there's not much experience in patients with PI. And we could use Salmonella typhi vaccine. This is an alternative to pneumococcal polysaccharide vaccine. And I think we're going to see, because of this Prevnar 20 issue, more patients being tested for a for a polysaccharide vaccine response, in this case, not to pneumococcus, but to Salmonella typhi by using this particular vaccine. And since immunoglobulin does not contain antibodies to this particular vaccine, this may be one vaccine we could use in patients who are receiving immunoglobulin replacement therapy as a test whether their antibody response is recovering and possibly taking them off immunoglobulin replacement therapy. Another vaccine that's available in Europe but not in the United States is tick-borne encephalitis vaccine, but obviously it's not available here in the States, so we can't use it. For those patients who have DiGeorge syndrome, there are times when we can use vaccines and catch up children with vaccines, and those children who have more mild DiGeorge syndrome. And here's some of the criteria as published by Tony Bonilla in Immunology Allergy Clinics in North America in 2020. They have a good response to non-viable vaccines such as tetanus and diphtheria. They have normal or near normal in vitro T cell responses to mitogens, and mitogens are PHA, phytohemagglutinin. I think those that have had this test will recognize that term. They have a CD8 T cell count greater than 300 and a CD4 T cell count greater than 500. So if they fulfill these criteria, then we can consider vaccinating with both conjugate vaccines as well as live viral vaccines in patients with mild DiGeorge syndrome. So what about other types of PI? So phagocytic defects, chronic granulomatous disease. Flu vaccine is particularly important because even in normal individuals, there's a comorbidity or mortality from staph infections if they get influenza, pneumonia, flu pneumonia, for example. Live viral vaccines such as oral salmonella vaccines or BCG should be avoided, but other live viral vaccines such as MMR and varicella can be given. Leukocyte adhesion defects or cytotoxic granule defects, such as in patients with Shiragaki syndrome, avoid live viral vaccines in these patients because an associated small defect in lymphocyte cytotoxic function. Innate immune defects, inactivated vaccines are safe and effective. So there are some examples here, IRAK4 and MyD88. They have a particular susceptibility to invasive pneumococcal disease. So it's important to give these patients conjugate pneumococcal vaccines like Prevnar 20. The same is true for congenitalized splenia, because they have a particular propensity to getting infected with encapsulated bacteria again, like meningococcal and pneumococcus. And complement deficiencies, particularly those that have late component abnormalities such as C5, C6, C7, C8, and C9, have a particular susceptibility to meningococcal disease, so they definitely should be immunized with conjugate meningococcal vaccines. Those patients have defects in interferon gamma and IL-12 pathway or NEMO have an increased susceptibility to intracellular bacteria. So live viral and bacterial vaccines are contraindicated, but they should be immunized with obviously killed and conjugate vaccines. So what about close contacts? Close contacts of patients with compromised immunity should not receive live oral polio vaccine. We don't use live oral polio vaccines anymore, so this really is not an issue. They can receive other standard vaccines because viral shedding is usually not present, and therefore they pose little risk of infection to patients with PI or compromised immunity. Particularly important is those that we recommend on an annual basis, such as influenza and scheduled periodic pertussis vaccine, pneumococcal vaccines, MMR, rubella vaccines, varicella vaccines if routine immunizations are not current. So with varicella vaccine, if a rash develops in a close contact after the immunization, which it rarely occurs, very rare, with varicella or zoster vaccines, and I'll go back to that in a minute, the risk of transmission to immunocompromised subject is minimal unless there's a blister that develops at the site of the vaccine where the vaccine is administered. And therefore, consider isolating the patient with PI, and even administering varicella zoster immunoglobulin for prophylaxis. The good news about zoster vaccine is that the zoster vaccine is now a component vaccine. So there's absolutely no risk at all because it's not a live viral attenuated vaccine anymore with this type of adverse event. A word about human papillomavirus vaccine. It's a non-infectious, 9-valent recombinant vaccine. Those patients who have a particular increased susceptibility to HPV should receive this vaccine because it's a recombinant vaccine. So, for example, in patients with WHIM syndrome and HIV infection, as well as others, in which warts is particularly an issue, and another is STOC8 deficiency, they should definitely receive this vaccine because they may get actual improvement in the cutaneous warts after receiving this particular vaccine. All PI patients should receive a yearly influenza vaccine. Although their antibody responses may not be robust, they still may develop a cellular immune response, which we think now is important in limiting the spread of the influenza virus into the lower airway. And all patients should receive the COVID vaccines, particularly the mRNA vaccines, is the ones that I highly recommended. And there's a lot of data on the immune response of PI patients to the mRNA COVID vaccines. The FDA has just approved another vaccine, the killed vaccine, component vaccine, RSV, respiratory syncytial virus for people over age 60. There's no data or recommendations yet in patients with PI. So I wish I had more information, but it is a recombinant vaccine, so it should be safe in patients with PI. So let me stop there and find out if there's any questions.
All right. Thank you so much.
And I'm going to unshare my screen.
Okay. I will. All right, here we go. So thank you so very much for that overview, Dr. Ballo. That was tremendous, and you answered quite a few questions that I know of. We now have some time available for the Q&A. Before we begin, please remember that everyone's treatment and condition are unique. The information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with questions concerning your medical condition. We have received some great questions so far, and we are ready to get started, Dr. Ballo.
Okay.
So the first one, I am a 54-year-old CVID patient. I have had COVID vaccines, all the COVID vaccines and boosters, and I get my flu shot every year. Should I get the Shingrix and Prevnar pneumonia vaccines, or are these antibodies covered in IVIG products?
Well, the Prevnar is covered. The Prevnar 20 is not going to hurt you to get the vaccine. It is, these antibodies are present in immunoglobulin replacement therapy. I encourage you to get the Shingrix vaccine. As I said, this is a two-part vaccine. You have to get part A and part B. I can't remember whether it's a 1 month apart or a couple months apart, but it's a recombinant vaccine now, so there's no risk to you. But you do not, want to get shingles. So please get the Shingrix vaccine.
Now, I'm going to chime in with a question of my own because I would like some clarification, and I think others will too. It was my understanding, and things may have changed, that because I have CVID and our children have it, my husband should not get the Shingrix because we could get sick, or if he got it, he should go somewhere else, or we should go somewhere else for a period of time. Is that still true? Or can he get it and we're good and we can also get it?
Yeah, that's what the old shingles vaccine.
Okay.
The new one is a recombinant, so it's not a attenuated viral vaccine.
Okay, so to clarify, everybody in the family can get it with the approval of their physician.
Correct.
Perfect. Thank you so much. Moving on. So I know when I was first diagnosed with CVID, the Pneumovax was given to me to see if I could mount an immune response. Is this an antiquated practice? Are there other testing vaccines that are a better choice? Also, every time this person has received the Pneumovax, they got severe cellulitis. I was told strep or staph was in the vaccine, but cannot find much information about this. Have you seen this in your practice?
Strep or staph is not in the vaccine. This I don't understand why. I don't know. I would have to question the administration of the vaccine by the healthcare provider, because this is a sterile vaccine. It may be a multi-dose vaccine, so there may be some considerations that that have to be inquired about whether whether the vaccine was administered from a multi-dose vaccine, which could present a problem, but does not contain live bacteria.
Yeah.
As I mentioned before, pneumococcal vaccine, we still use this as a diagnostic vaccine for evaluating whether patients can make specific antibodies to polysaccharide antigens, namely pneumococcal polysaccharide antigens. But with Prevnar 20, going forward, we may have some difficulty interpreting the results in an individual. For example, if they have received a Prevnar 20, since this is a conjugate vaccine and since this is a T-cell dependent vaccine, patients may have a robust response that may last a long time. So therefore, as I talked about before, we may substitute Salmonella typhi vaccine, which is a polysaccharide vaccine. It's not a live viral vaccine.
How often do people get the Pneumovax and then have repeat titers done 6 months to a year afterwards to see if they have retained those antibodies?
Yeah, frequently.
Mm.
And I'm trying to discourage my fellows from doing this. I think that my approach that if I give a patient with suspected PI, now I'm talking about a patient that may have selective antibodies, not CVID,
Okay.
and they have a good response to Pneumovax. Let's just say they have a good response to Pneumovax. More than 50% of the serotypes have an adequate antibody response. I will see them back at 6 months. If they are doing well, I will not obtain titers again. If I see them back at a year, I will obtain titers again to see whether, where those titers fit in with the original response. We know that there are some patients with selective antibody deficiency that have what we call a memory phenotype. And that is, they initially respond well, but they don't remember that they responded well. And therefore, their antibody titers leave them. They go down precipitously. Now, as I've said before, because it's a T-independent vaccine, in everyone, the antibodies titers go down. So if you check the titers, 2 years, 3 years, 4 years out, all bets are off. It's very difficult to interpret because even in everyone, the titers will wane. Not like a tetanus or diphtheria or other conjugate vaccines.
And that's a question that somebody has asked. I may have missed this, but is it not effective to use the tetanus vaccine to test for immunity?
Yeah, it is. But I would say more than 75% of my patients with CVID respond well to tetanus. And as I said before, this is a conjugate vaccine.
Mm-hmm.
So it's a T-cell dependent vaccine. And usually they've received not only their childhood tetanus vaccine, but a booster vaccine at age 5, and may have received another booster maybe as a teenager. And now they've developed CVID, say at age 30 or 40 or in their 50s, and they have pretty good titers. And yes, we can still give the tetanus vaccine, but in the majority of the patients, they actually respond quite well because they have long-lived memory B cells and long-lived memory plasma cells. So it may not be as helpful diagnostically. But if a CVID patient in their initial antibody screen do not have very good levels to tetanus, then yes, we do give them a tetanus booster to look at their response.
Okay, thanks. Are vaccines safe if I'm on IVIG and antibodies are normal, but CD4 cells around 200 and CD3 is less than 300?
Well, again, I think we would use an inactivated or conjugate vaccine and not a live viral vaccine if the T cells are on the low side. Yeah, we don't want to give patients with, that patient would fall into what we call a combined immunodeficiency. And we would not want to give them live viral vaccines, just as a precaution. And, the IVIG does contain specific antibodies to many of those viruses, so they would be protected.
My doctor recently retired and the guidelines have changed with influenza vaccines. I have been advised to get two times high dose quadrivalent influenza shots. I think they mean two of each flu season, largely because my mounted immune response does not last an entire flu season. I did this many years and it saved me a lot of trouble. However, now I cannot get even one high dose shot or more than one influenza vaccine in a year. What are your thoughts on this?
Yeah, I have not heard that approach. It sounds interesting, but you should be able to get there is what they call a high dose for individuals over 65. And I think if you explain to the pharmacy that you have a primary immune deficiency, and explain why it's important to get the high dose influenza vaccine, hopefully they will accommodate you. And I certainly agree with getting the high dose influenza that's right now is pegged towards patients. I don't know if it's over 60 or over 65, something like that.
What do you recommend for PI patients who have a history of allergic reactions to vaccines?
Yeah, that has to be more specific. I mean, it's unlikely that it's to all vaccines. There may be some caveats, as I mentioned before, with a preservative, or some vaccines may contain an antibiotic that the individual is allergic to. I think it's unusual to be allergic to all vaccines, but that should be evaluated by an allergist / immunologist to determine what the nature of the allergy is and what the component may be in a certain vaccine to which the person may be allergic to.
Are you aware of hyperactive reactions in patients with immune dysregulation? This person has had autoimmune hepatitis from one vaccine, multi-system inflammatory system from another, and some specialists do not acknowledge the possibility and they continue to include vaccines in their treatment plans.
Yeah. I am not aware of this, but I assume that it's possible that any kind of event, perhaps even a vaccine event in someone who has immune dysregulation, could lead to an inflammatory response. I have not seen anything in the literature about vaccines causing this, but it's may not be impossible.
Question, should we have titers taken prior to getting a tetanus vaccine to see if it's even needed?
Yes.
Interesting. How many vaccinations can a person receive without risking an autoimmune inflammatory response?
I have not seen any literature or discussion of association of vaccines and getting a hyperimmune or a hyperinflammatory response. I have not seen that issue discussed or addressed at least in the literature that falls into immune deficiency.
At what age should you get the shingles vaccine?
Well, it's approved by Medicare, so obviously if you're 60 and over, Medicare is going to cover it. It just depends whether insurance will cover it or not.
What if you've already had shingles? This person had shingles before they were diagnosed with CVID 15 years ago and are asking, should they get the shingles vaccine?
Yeah, I've heard. Yes, I think that if you receive the shingles vaccine, it may attenuate any further shingles episode. So I think that's probably a good idea. Yes.
My pneumonia titers that were less than 1.3 have not gotten any better with IG replacement therapy. Why?
Yeah, there was a period of time when we used to measure, pneumococcal polysaccharide antibodies, in patients, receiving immunoglobulin replacement therapy, and then trying to use that as a guide whether to change the dosage of immunoglobulin replacement therapy. That has kind of gone out of favor over the past 5 years or so. So we do not routinely measure, pneumococcal antibodies in patients on immunoglobulin replacement therapy. Different lots of immunoglobulin may contain different levels of specific pneumococcal antibodies to the different serotypes, and therefore, I think it's very, very difficult to make a consistent statement. There really hasn't been a true controlled study on using the antibody levels to pneumococcal polysaccharides in patients on immunoglobulin replacement therapy as a guide to, whether to change the dose of immunoglobulin replacement therapy. So I'm going to have to put that one aside.
Should PI patients get emergency tetanus shots if they are bitten by a dog, step on a rusty nail, etc.?
Sure, it's not going to hurt them. Yeah, and as I said before, because of their prior exposure and long-lived memory plasma cells and B cells, they may respond.
Does taking Tylenol or Motrin after a vaccination in order to help with vaccine side effects end up blunting the effectiveness of the vaccine?
I'm not aware that occurs. I've never seen that.
You mentioned that the HPV is immunogenic with WHIM. Is this a good or bad thing? And should the vaccine be avoided in patients with WHIM?
No, I had said before that it's a recombinant vaccine. Therefore, WHIM patients who have a propensity of getting warts, as the name suggests, should receive this vaccine, because in those patients that receive the vaccine, there is some literature that their warts actually abate or partially disappear.
I have a couple COVID vaccine questions. I had a swollen salivary gland response to my second Moderna vaccine. Subsequently, I took Novavax as my third. Would you recommend a second Novavax since I continue to be reluctant to take another mRNA? I have CVID and wonder how effective these vaccines actually are.
Actually, it's surprising that the vaccines are effective in many of the patients with immune deficiency, even in those patients with CVID. I can't comment about the Novavax because I haven't reviewed the data. Most of the data is actually on the mRNA vaccines. But I guess if you've had a side effect, that getting a booster with the Novavax is certainly not going to it's not going to hurt you. So I think it'll be fine. I think it's the risk of getting COVID in a patient with underlying immune deficiency is much greater than any kind of potential side effect from the vaccines.
And I can tell you from personal experience, I've now had COVID 4 times, 4 different variants, and I can almost tell you to the minute my T cells start to work. I had all my vaccines and my body knows something. And I've heard that from a lot of people, that you get sick, but you can tell the second your body starts to know what to do and you start to recover. So it's been very interesting. Not that I wanted to be a human experiment. What COVID vaccination type and schedule do you recommend for those with PI, especially since Evusheld has been pulled? And I will say that there is on the CDC site an actual vaccine schedule, but what are you recommending for next steps right now?
Well, I think, PI patients should get COVID vaccines. The bivalent vaccine was approved a while back ago. There's going to be a new bivalent vaccine that's going to be available in September. I've seen that reported by the FDA. I don't know any more details about that. I also understand that there may be a new monoclonal antibody mixture from the makers of Evusheld that will be available also maybe in the fall. So keep our fingers crossed that we'll have a new prophylactic monoclonal antibody reagent that we can use.
Can you talk about the timing of the vaccines? So if somebody has had a previous booster, how long do they wait till the next one?
Well, it depends on the circumstances. I mean, I don't, that's pretty up in the air. It depends on whether they're on immunoglobulin replacement therapy, because a lot of the immunoglobulin has a lot of these specific antibodies. So we don't give routine boosters to patients except for influenza and COVID vaccines are the two that we use routinely on. Well, we probably will use COVID on a yearly basis. We certainly use influenza on a yearly basis. And Shingrix, I think, all patients should get the Shingrix vaccine because it's a component vaccine.
And we have time for one more question. And well, 2 real quick ones. Will getting a COVID vaccine help with a recent exposure?
I'm not sure what they mean by that, because it could take up to 2 weeks to develop an antibody and a cellular immunity to COVID. So if they've had a recent exposure, they should know in about 5 to 10 days whether they're going to come down with COVID. So if they don't come down with COVID in that kind of incubation period, then they're probably safe.
And the last question is Actemra still being used for those in the hospital with COVID?
I'm not sure what that is. What?
Yeah, I have not unfortunately heard of it either. Well, I thank everybody, and Dr. Ballo, I can't thank you enough for the awesome answers to these fabulous questions that we received. But unfortunately, our time has come to an end. I want to thank everyone for being here this afternoon, for taking the time out of your busy schedule to participate in this session, and I hope you learned a lot. If you have further questions, you can reach out to us on the IDF website through Ask IDF resource. This session is one of 39 unique learning opportunities provided through our 2023 conference, and we hope you will continue to tune in today to the remaining sessions that we have. And I hope that you will attend a keynote for this afternoon, because it's going to be very exciting. So thank you very much for being here. Thank you, Dr. Ballo, for your expertise.
You're welcome.
And I wish everyone a healthy and happy weekend. Thanks for being here. Bye.
Bye-bye. Bye.